Thank you. Thanks, everyone. Can you hear me okay? Good. So I'm very grateful to be working for Justin. He obviously brings his own lived experience that he's so open about and has such passion for ketamine treatment. Now, I have some slides. Let me see if I can, there we go. So in about 10 minutes, I'm going to try to give a quick, very brief sort of overview of ketamine from more the medical standpoint and sort of what it is, how we're using it, and get a bit of a better understanding of that. So there we go. So I'm going to start with what is ketamine, take a look at who may benefit from ketamine, what we know about how it works, what formulations it comes in, and touch on the safety of ketamine as well. So to start with, what is ketamine? So it is classified as a dissociative anesthetic. It was first synthesized in 1962. It was found to be actually one of the safer anesthetic agents because it causes less respiratory depression. So often it's even used in procedures without the need for people to be intubated. And it's used with humans, it's used with pediatrics, and it's also used in veterinary medicine. So it has a bit of a reputation as being kind of a horse tranquilizer or something used for vets only, but it's actually used quite extensively with humans as well. And so it's a dissociative anesthetic. At high enough doses, it does cause loss of consciousness. Dissociation occurs more in kind of like moderate to lower doses. And for everyone, they describe that experience differently. I know Justin sort of touched on a bit about his experience. Generally, it's a feeling of kind of being in a dreamlike state. Some people describe having out-of-body experiences. Some people hallucinate. And that can happen during the experience of having ketamine. So when we talk about who may benefit from ketamine treatment, this is an area where I think and I hope is going to evolve over time as we learn more and more about ketamine. At the moment, right now, it is used exclusively for treatment-resistant depression as well as acute suicidality. So treatment-resistant depression is defined as someone who has had and failed at least 2 what's called guideline concordant trials of an antidepressant treatment. So what that means is they must have tried antidepressants in adequate dose for a minimum of 6 to 8 weeks. As Justin said, that can feel like an eternity to someone who's quite depressed. So we're looking at people who've had at least 2 trials of those and failed to respond. So often we see people at our clinic who've had many more trials than that, who've been through multiple medications and treatments. But at this point, we kind of see that as a minimum. So right now, our Canadian treatment guidelines for the treatment of depression specify that ketamine should be considered a third-line treatment, which really, like I said, means you've gone through 1, 2 trials, consider ketamine. It's also other treatment-resistant depression treatments include electroconvulsive therapy, transcranial magnetic therapy, so other treatments out there as well. And what's interesting about ketamine is it does have quite a much more rapid onset. So that's why it's also seen to have this acute sort of anti-suicidality benefit, where within 4 hours, people who have had intense suicidality will report that those thoughts have gone away. And that can then peak around 24 hours and beyond. So that is kind of where we're using it right now. There's certainly a lot of interest and research being done in other areas, anxiety disorders, OCD, PTSD. So that is sort of one of those evolving pictures as we learn more about ketamine, as there's more trials done, so we learn about, who does it help and in what context. So in terms of how it works, the bottom line is actually we don't know. So there's a lot we don't know, even about traditional antidepressants. People talk about serotonin, norepinephrine, dopamine. We have a pretty good idea, but there's still stuff we're learning every day about antidepressants and how they work, and ketamine is certainly no different. As Justin mentioned, it's a non-competitive NMDA receptor antagonist. Essentially, that means it increases glutamate in the brain, which is pretty ubiquitous, meaning it's throughout the brain in different regions and structures. So knowing that it increases glutamate itself doesn't necessarily point us in terms of having a clear understanding of what that means. It also acts in other systems, for example, the opiate system. in the brain. It also, what's really interesting though, is that when it blocks this NMDA receptor, what we see is this kind of in the cell, in the brain cell itself, we see what's called a downstream effect of increase in something called brain-derived neurotrophic factor, which is BDNF. BDNF has been called a brain fertilizer. So what that is it's a molecule that seems to help cells grow, and in particular, as Justin mentioned, these dendrites, which are sort of the little outgrowths on the neurons themselves that are kind of the receptor where how the neurons talk to each other seem to grow and flourish when there's in this environment where there's BDNF. So that is believed to be one of the main mechanisms with ketamine, is that this BDNF is really important to help with cellular growth and neurotransmission, areas that are impaired in depression. Now, when we look at it from a neuroanatomical level, there's a lot of different regions, and the brain is kind of its own universe. So there's all these different regions, they communicate with each other in different ways, and there's a lot, again, we're still learning and trying to understand. I just wanted to highlight one region of interest, amongst others, which is it's called the subgenual anterior cingulate cortex. And this is an interesting region because it seems to be overactive in depression. And the understanding is that that may relate to sort of depressed individuals kind of having almost negative ruminations, and their thoughts are sort of on overdrive about everything that's kind of negative, being really sensitive to any kind of negative feedback in the environment, sensitive to perception of threat. And on the other hand, also being almost completely oblivious to any sort of positive things, not being able to experience pleasure, not being able to even anticipate the experience of pleasure. And so this region seems to be overactive in depression, and when we see individuals who antidepressants have worked for, there's a reduction in activity in this one region. And what we do know is that ketamine seems to have very rapid activity in this one region of the brain, both during the actual infusion itself, so if you're receiving ketamine, almost immediately we see changes in this region in the brain. There's a number of other areas it works in, for example, the prefrontal cortex, and there's connections between all these areas. So areas that are involved with helping us experience emotions and helping us understand the environment we're living in and interpret the emotions and feelings we're feeling inside our body and outside the world. So I think at the end of the day, we actually still have more questions than we do answers about ketamine. Eventually, I hope that through this journey, as we try to learn more about ketamine, we're going to learn a lot more about depression and a lot more about the brain along the way. So in terms of kind of the nitty-gritty of how ketamine is given, it's available in a number of different forms: oral, kind of lozenges, intranasal, in like what's called subcutaneous, so under the skin injections, intramuscular injections, or intravenous injections. So far right now, the most robust evidence for treatment of depression is the intranasal or the IV formulation. The main reason for that is that the IV is kind of the gold standard because the bioavailability, meaning the amount of the drug that you're given that your body actually uses in the way you want it to, approaches 100%. When you give it intranasally, it's somewhere between 30 to 50%, and so it can be quite variable from person to person. And orally, it's even lower. It's between 10 to 30%. It can vary from person to person. It can even vary from the same person day to day. So when you're trying to dose a medication, it becomes a lot trickier when you're looking at other formulations. Now I'm going to wrap up with the question of, is it safe? So this is not my car, I wish, but just to kind of use the analogy of, when I'm asked that question, is it safe? I often say it's not a yes or no question. Like, nothing is safe or not safe. A race car is safe if you know how to drive it, or if you're wearing a seatbelt and driving, appropriately, following the rules. Similarly with ketamine, it can be very safe, but it can also be not safe, as everyone's heard of, what happened with Matthew Perry and that tragedy. For example, at our clinic, it's given in a safe environment with anesthesiologists and trained ICU nurses who are supervising the entire treatment. So in Canada, ketamine is a Class 1 drug under the Controlled Substances Act. So that means that it is not legal for sale, use, or distribution outside of a medical, industrial, or scientific setting. So individuals are not given ketamine to take home. It's just used in this sort of controlled way. As well, in order to even get ketamine, at our clinic, as well as many other clinics, you have to go through a process of meeting with a psychiatrist, myself, or one of my colleagues, to number one, determine eligibility. Is this actually treatment-resistant depression? And therefore, would you be eligible for treatment? But also to look at potential medical contraindications. So if there's individuals, for example, with uncontrolled heart disease, things like that would put you at more risk with using ketamine. So we try to screen out anyone who's too high risk to use ketamine, and then we use it in a safe setting. So I think those are kind of the key takeaways from that that I'd like you to think in mind. With that, I'm going to wrap up and pass it over to Naomi, who's our therapist. But I just want to say thank you. I hope that you have more questions about ketamine than answers, because I think that would be reflective of sort of where we are. But it's a very exciting area to be working in. It's an area that is always growing, and we're learning so much more. And I find it very rewarding to be working with so many patients I see get better, who have been suffering for a very long time. So I'm appreciative of the opportunity. So thank you.
Hi. I'd like to share with you the story of a hopeful patient who had carried the sadness of a traumatic childhood through the first 3 decades of her life. Feeling like a burden since she was too young to even understand why she would feel that way about herself, this patient experienced an acute sense of worthlessness and shame, nurtured in no small part by her consistently unavailable mother.